Uh, Good evening, everyone. I, Dr. Shreya Lal, on behalf of entire MQ Pharmaceuticals Limited team, welcome all of you. It is my great pleasure to introduce our speaker for today's webinar. This individual is a true luminary in their field, possessing a wealth of knowledge and expertise that is certain to captivate and enlighten all of us. Allow me to introduce Dr. Mika Satyanarayana sir, who has made significant contribution towards HIV treatment, prevention, and education. Throughout this webinar, Dr. Satyanarayan sir will be sharing their valuable insights on recent updates on PrEP and PEP. Allow me to take this opportunity to introduce Dr. Satyanarayana sir. So, sir is practicing HIV/AIDS medicine at Kukatpalli, Hyderabad since 1998. Sir visits rural areas in Telangana where the HIV prevalence is high and provides treatment services to the needy at affordable costs. Sir is director at Aswini HIV Care and ID Clinics at Kukatpalli, Hyderabad. Sir has conducted several CMEs on professional platforms and awareness programs in electronic, social, and print media. Sir has graduated from Andhra Medical College, Visakhapatnam, and has undergone training in HIV/AIDS medicine from NACO, Grant Medical Foundation and the University of South Florida, Harvard Medical School, Boston, and Johns Hopkins, Baltimore. Sir has participated in several knowledge-acquiring conferences in HIV/AIDS at Glasgow, CROI in San Francisco, Washington, D.C., Kuala Lumpur, Johannesburg, and Melbourne. Sir is a member of International AIDS Society, life member at AIDS Society of India, member of Treat Asia, lifetime member of HIV Medicine Association of India, and life member Infectious Diseases Society of India. So, without further ado, let me warmly welcome Dr. Satyanarayana sir as they take the virtual stage for today's webinar on recent updates on PrEP and PEP. Over to you, sir. I'll now stop sharing the screen. And welcome once again, sir. So we can see your screen. Yeah.
So this is okay, madam?
Yes, sir.
Thank you, madam. Thank you very much for your kind introduction, Shreya madam. Good evening, everybody. Shall I start?
Yes, sir. Definitely.
Yes, sir.
At the outset, I thank MQ Pharma for giving me this great opportunity to talk on pre-exposure prophylaxis. That is usually commonly called as a PrEP in the context of preventing transmission of HIV in high-risk vulnerable individuals. First of all, let us see the recent demographic scenario of HIV in India. India has the second largest HIV burden in the world. The overall adult HIV prevalence rate in India remains low for the last few years at around 0.21%. But in key populations like female sex workers, the prevalence is 9 times higher. And among MSMs, it is 16 times higher. Among the transgenders, it is about 18 times higher. And among IV drug users, it is it is alarmingly 43 times higher than the overall adult prevalence rate. In these settings, prevention of transmission in high-risk vulnerable populations is very, very crucial to avoid the further spread of HIV disease in the community. The recommendations that we are going to discuss now are mostly from Western world, mostly from Center for Disease Control, CDC. In the US, nowadays, 20% of all new HIV infections are from people aged between 30 to 24 years. And 81% of all those newly diagnosed were from young MSMs, many of whom could not able to access the PrEP facility. The same situation may also prevail in our country very soon. In this scenario, many vulnerable adolescents and young adults can benefit from PrEP. This is the reason why scaling of PrEP is very, very important. Till now, PrEP is not very popular in our country. National technical guidelines for PrEP were introduced by NACO in 2020. As of date, PrEP is not introduced into the national program. All of you must have known that there are 4 transmission routes shown in this picture. But nowadays, most HIV transmissions occur through anal or vaginal sex and sharing of needles and syringes. Transmission through blood and blood products and mother to child has become very, very infrequent because of the screening of blood and blood banks and the PPCT program being conducted by NACO. Among the different modes of sexual transmission, unprotected anal sex, either it is insertive or receptive, and unprotected vaginal sex, either it is insertive or receptive, are very common. Through unprotected oral sex, HIV transmission occurs very, very infrequently. As all of you must know that ART, which was introduced in 1996, has changed the outlook of HIV and AIDS in India, not over India, over globe, to a virtual death sentence to a chronic manageable disease like diabetes and hypertension. Now, with a successful antiretroviral treatment, the HIV infected can lead a near normal life or a lifespan with good quality of life. Previously, we used to advise all the serodiscordant, even sometimes seroconcordant couples also, to follow safe sex practices by using condoms. Nowadays, we must be proactive in telling all these serodiscordant couples in our day-to-day clinical practice to consider condomless sex, which is not at all risky if the positive partner is on ART with good adherence and maintains undetectable viral loads. This is a very important scientific advancement in the treatment of HIV, we can say. Be proactive to communicate this message to all, even to our own professional colleagues who may not be knowing this, that U is equal to U is undetectable is untransmittable. Another important aspect is treatment as prevention is the most important advancement in terms of quality of life, improving the quality of life in HIV-infected individuals. In this HPTNO 5-2 study, early initiation of ART reduces the risk of transmission of HIV in serodiscordant couples as compared to delayed initiation of ART. In the partnership study, which is an observational study, looked at the risk of transmission of the virus in any form of sexual intercourse, either anal or vaginal, or in any group of heterosexual men or women, or in MSMs. If the source seropositive partner is undetectable, the risk of transmission to the seronegative partner with unprotected sex is almost zero. Among these HIV transmission preventive strategies, so biomedical, pharmacological, behavioral, structural, constitutional, the PrEP plays an important role in seronegative high-risk individuals. We know the PrEP concept is there for more than a decade, but it has not become a very popular one. Nowadays, we see a lot of educated MSMs coming to our clinics and proactively asking for PrEP. PrEP should be offered as a part of combination preventive strategies that includes condom usage and the different behavior strategies seen in this slide. So this is the overview of the topics that I am going to cover under these headings in the next 45 minutes or so, if time permits. So first thing is, why do we need PrEP? To some extent, we have already discussed the importance of PrEP, why it should be needed now. Evaluating the PrEP safety and efficacy. Who can prescribe the PrEP? Who can benefit from the PrEP? What should we know before prescribing the PrEP? And guidelines for prescribing the PrEP. Are there any consideration in the special populations? And lastly, we will review the entire presentation. Let's begin by knowing what is PrEP and why do we need it. So coming to the definition of the PrEP, PrEP is the use of antiretroviral medications by people without HIV to protect themselves from getting HIV. PrEP is recommended for adults or adolescents weighing at least 35 kg and usually for those who are at the risk of getting HIV through sex or IV drug usage. 3 medications were approved for use as a PrEP. 2 medications are taken orally among these 3 and consists of 2 drugs combined into a single pill used daily. The composition of the pills are tenofovir disoproxil fumarate 300 milligrams in combination with emtricitabine 200 milligrams, usually known as TDF-FTC. Another pill is tenofovir disoproxil fumarate 300 milligrams plus lamivudine 300 milligrams, known as TDF-3TC, is recommended by NACO from 2020 or so. Third preparation is tenofovir alfanamide 25 milligrams in combination with emtricitabine 200 milligrams, known as TAF-FTC. Note that this TAF-FTC is not approved for use by women or other people who could get HIV through receptive vaginal sex. It is used mostly only in MSMs. It is approved. The third medication is a injectable formulation recently approved by FDA, that is cobatagravir 600 milligrams given once in every 2 months as an intramuscular injection by a healthcare provider in a hospital setting. At present, it is very expensive and it is not available in India. Our pharma companies are trying hard to bring it with a generic in the market soon. The major advantage of PrEP is that it adds another effective HIV preventing option or tool to the list of preventing strategies earlier we discussed in the previous slide. It is not to be consumed for lifelong. That is one major point. Rather, it can be started during periods of higher risk, and as well, it can be stopped during the no risk periods. Now, let's take a look at the clinical evidence for PrEP efficacy and safety. A very, very important aspect. Coming to the PrEP efficacy. PrEP has been demonstrated in multiple studies as a highly effective tool when taken as prescribed. PrEP's effectiveness varies between transmission routes. When taken as prescribed, PrEP reduces the risk of getting HIV from sex by about 99% and from IV drug use at least by 74%. It should be noted that the estimated effectiveness for people who inject drugs is studied based on tenofovir usage alone. So the effectiveness of 2-drug oral therapies containing tenofovir may be higher than this 74%. But PrEP's effectiveness is highly dependent on adherence. With missed doses, the effectiveness will be naturally decreased. We discussed earlier, there are 3 types of PrEPs are generally, all these 3 types of PrEPs are generally well tolerated, with side effects that may usually mild to moderate in severity. They are manageable and they are temporary. Less than 10% of patients only will get the side effects. Those who initiated on oral PrEP with TAF FTC or TDF FTC or TDF lamivudine, that is TAF FTC, TDF FTC and TDF 3TC or TAF FTC, they report experiencing some sort of startup syndromes. These syndromes are typically consist of headache, nausea, and abdominal discomfort and does not last longer than 1 month. The symptoms can usually be managed with symptomatic medicines like over-the-counter medicines like NSAIDs. But no startup syndrome has been reported for patients starting on injectable PrEP, that is cabotegravir. If a patient is concerned about side effects in injectable PrEP, an optional 4-week lead-in period of daily oral cabotegravir can be prescribed before the patient receives the first dose of injection. Coming to the kidney safety, the use of TDF FTC, TDF 3TC for PrEP was associated with a small decrease in creatinine clearance that did not get worse and return to normal levels once the patient stops using the drug. TAF FTC is associated with a lower risk of kidney-related side effects. No risk of kidney-related side effects has been reported with injectable PrEP, cabotegravir. That is an advantage with that. All patients starting on oral PrEP should have their creatinine clearance checked and then monitored while they are using the PrEP. TDF FTC or TDF 3TC in MSMs was observed to be associated with a small decrease in bone mineral density, but this decrease was not associated with increased incidence of fractures. There are no reported bone safety issues for TAF FTC or cabotegravir. But injection site reactions are common in patients receiving cabotegravir and typically include pain, tenderness, and swelling of the skin at the injection site. These reactions typically are mild to moderate, usually last for a few days after the injection, and can be managed with over-the-counter painkillers. They usually decrease in severity after the first or 2 or 3 injections. Coming to weight gain. Weight gain and increased triglyceride levels have been observed in patients using TAF and FTC. Weight and lipid levels should be monitored in patients using this drug. TDF FTC or TDF-3TC and cabotegravir have not been reported to affect weight or lipid levels. This clinical trial data suggests that there is no increase in the behavioral risk with the use of PrEP. The charts in the left show that among at high-risk men who have sex with men, that MSMs, the number of sex partners, the incidence of condom use were similar when the participants were prescribed PrEP or placebo. That means there is no increased behavioral risk with PrEP. The chart in the right presents the results of the Bangkok trial, that is Bangkok tenofovir study, which showed a general decrease in HIV acquisition due to IV drug use when PrEP was included in the HIV prevention strategy of their government programs. Let us know who can prescribe PrEP in our regular day-to-day clinical practice. As per our national technical guidelines given by NACO in 2020, PrEP can be prescribed by any registered medical practitioner qualified in modern medicine, preferably trained in national guidelines. The prescriber he need not to have be an infectious disease specialist. PrEP can be given by a general physician also, HIV caregiving physicians, sexually transmitted treated infectious treating venereologists, and of course, substance use treating physicians, psychiatrists also can prescribe PrEP. We have to understand that PrEP is a preventive measure for HIV that can be readily integrated into primary care. As primary care physicians, regularly prescribing the preventive measures like metformin for pre-diabetics, statins for those who are at the risk of getting cardiovascular disease, and oral contraceptives for the prevention of unintended or unwanted pregnancies. Similarly, PrEP also can be prescribed as a preventive measure. In fact, making PrEP available in primary care settings as a part of routine preventive health care, it can improve access for all the needy who could benefit from PrEP. It also helps to address the existing disparities in PrEP uses. Till now, we have covered an introduction, what is PrEP, and the PrEP medications available in the market. Let us move to discuss who can benefit from PrEP. PrEP is extremely useful to those who are unable to wear or negotiate condom use with their partner or partners, or people who inject drugs but are not able to obtain new injection equipment, or people who do not use condoms or new injection equipment consistently for whatever the reason behind. PrEP is for adults and adolescents without HIV who are at risk of getting HIV from sex or injection drug use, as we discussed earlier. As per the 2021 CDC PrEP guidelines, we should inform all sexually active adults and adolescents about PrEP as a graded recommendation 3B. Giving patients information about PrEP equips them not only to take steps to protect themselves from HIV, but also share that information with the social networks and other friends and all who may be benefit from PrEP. Making conversation about PrEP can help patients to overcome embarrassment and stigma so that they can respond accurately to risk assessment questions. Now, we know that registered medical practitioners of modern medicine with little training in national program guidelines can prescribe PrEP and PEP. Now let us talk a little about what prescribers should know before prescribing PEP. Remember, PrEP does not prevent sexually transmitted infections like syphilis, gonorrhea, hepatitis B virus, herpes simplex virus, chlamydia, etc. Of course, it also doesn't prevent unintended pregnancies. Coming to the importance of taking sexual history. Obtaining a sexual history is recommended for all adult and adolescent patients as a part of ongoing primary care. However, a comprehensive sexual history is not required to advise PrEP. Healthcare providers can introduce the discussion about the patient's sexual history by emphasizing that these are routine questions and that everything they talk about will be kept confidential between the patient and doctor. We have to give that reassurance to the patient. While taking sexual history, adopt the 5Ps strategy. 5Ps means determine the partner's practices, protection from STS, past history of STS, pregnancy intention. Means determine the number and gender of sex partners, inquire about the high-risk practices, discuss the risk reduction strategies, and the need for STI testing. Discuss protection strategies to prevent STIs. Inquire about the history of STIs in the past. Having a history of STI can place the patients at a greater risk of acquiring HIV. Discuss the pregnancy intention plans. So these are some more examples of a brief risk assessment questions. It is important to talk to all the patients who may be at risk of HIV through sex or injection drug use. Starting the conversation by informing patients about PrEP and its benefits, and respond openly to questions about their sexual and drug use behaviors. Once you have introduced PrEP, begin to ask the patient about their sexual behaviors. Assure them that these questions are routine and the information they shall, as we discussed earlier, will be kept confidential. Be sure to use a local language which is understandable or which is familiar to the patients. So now let us talk something about the guidelines for prescribing PrEP. This is a CDC recommendation algorithm for assessing a sexually active patient for PrEP. This algorithm includes a brief set of questions designed to assess key risk factors for getting HIV. PrEP should be prescribed for patients who have a sexual partner with HIV, who has an unknown or detectable viral load, or patients who have one or more sexual partners of unknown HIV status and have not consistently used condoms, or patients who have had a bacterial STI in the past 6 months period. It is important to note that sometimes the patient may request PrEP to protect themselves from HIV, but not feel comfortable reporting HIV risk factors because they anticipate receiving stigmatizing responses from the healthcare workers. For this reason, patients who request PrEP should be offered regardless of their risk assessment responses. This slide is for assessing persons who inject drugs for PrEP. The slide presents a recommended algorithm for assessing a patient who injects drugs for PrEP and include questions about their risky injection practices. PrEP should be prescribed for patients who have injected drugs within the past 6 months and shared their syringes and needles. This is a very important step in before giving a PrEP a laboratory assessment. Baseline laboratory testing should be performed prior to starting of PrEP with either oral medication or injectable cobitegravir. First of all, we have to do a HIV test to confirm that the patient does not have HIV. Laboratory-based HIV antigen antibody tests are the preferred method, but a minimum documentation of negative antibody test within 1 week before the patient initiated PrEP is required. If patient is been reinitiating on PrEP and used oral PrEP within the last 3 months or injectable PrEP within the last 12 months, testing should include an antigen antibody test and a qualitative or a quantitative HIV-1 RNA PCR test. Oral rapid HIV test should not be used to screen PrEP candidates for HIV because they are less sensitive than blood tests. Any patient with a reactive test should be linked to HIV care and treatment. Acute HIV should be suspected if the patient reports a recent exposure. Ask all PrEP candidates with a negative or indeterminate HIV test result about whether they have experienced any signs and symptoms of acute retroviral syndrome in the month prior or on the day of evaluation. Coming to kidney function. Kidney function must be assessed for all the patients initiating on oral PrEP. When used as a PrEP, TDF can cause a mild decrease in kidney function, usually remain within the normal range, and it is of no clinical significance. Typically, it reverses when the patient stops PrEP. Occasional cases of sometimes acute kidney failure, including Fanconi-like syndrome, have been occurred and reported. Kidney function should be assessed by calculated estimated creatinine clearance, that is with estimated GFR, eGFR, using a Cockroach-Gull formula. TDF FTC is approved for use in people with eGFR more than 60 ml per minute only, and TAF and FTC is approved for use in people with eGFR of more than 30 ml per minute. As you know that TAF is protective to some extent. Kidney function does not need to be assessed for patients being prescribed on injectable PrEP because injectable cobitegravir doesn't have any renal side effects. Additional baseline laboratory testing prior to PrEP initiation includes hepatitis B screening. All patients being prescribed on oral PrEP should be screened for hepatitis B virus presence. In people with active hepatitis B virus infection, sometimes stopping oral PrEP medication can result in a rebound of HIV replication, leading to fulminant liver damage. HBV infection is not a contraindication to oral PrEP, but patients with active HBV infection should be educated about the risks of stopping PrEP abruptly so that their liver function can be monitored closely for the reactivation of hepatitis B virus. In the Discover trial, so it is sorry for the interruption. So we discussed this now.
Yes, sir. Yes, sir.
I lost somewhere. Anyway. So, in the Discover trial, comparing TAF and FTC and TDF and FCC and TAF and FCC for PrEP, participants taking TAF and FTC showed higher rates of triglyceride elevation and weight gain. All patients using TAF FTC should have their lipid profiles done. This is the burning issue now with all this weight gain, even with combination with integrase inhibitors with TAF. So lipid profile should be done and should be prescribed a lipid lowering agents like pitavastatin, most probably presently not available in India if it is indicated and available. Regarding STI infections, all PrEP candidates should be screened for chlamydia, gonorrhea, and syphilis. So these are the ongoing assessment for patients using oral PrEP. The 2021 updated PrEP guidelines recommends a schedule of ongoing assessments. So maintaining PrEP on patients with the laboratory data is also very crucial. So these recommendations reflect the minimum investigations, and healthcare providers should conduct additional assessment if really warranted. So these assessments should be done every 3 months, 6 months, and 1 year. And at least once in every 3 months, repeat HIV testing and assess for signs and symptoms of acute infection to confirm that patients are still HIV negative. This is a very important step. At any point of time, a PrEP candidate may become HIV positive because of poor adherence or risky behavior. Provide a prescription or refill of oral PrEP medications for not more than 90 days. So until the next HIV test. So giving a long duration is not also, long duration refills also not advisable. Assess and provide support for adherence and risk reduction behaviors. Test all the sexually active patients with the signs and symptoms of sexually transmitted infections. Screen asymptomatic MSMs who are at high risk of recurrent bacterial STIs, and provide access to sterile needles and syringes and substance use disorder treatment services to people who inject drugs. Respond to any new questions from the patients and provide them with any new information about the PrEP usage. Coming to every 6 months assessments, monitor estimated GFR level for patients who are over 50 years of age or who had a eGFR under 90 ml per minute when they started the oral PrEP. If there are any other threats like kidney safety, such as hypertension or diabetes, kidney function should be monitored more often or checked using additional tests like urine analysis or proteinuria, etc. A rise in serum creatinine is not a reason to withhold PrEP. If eGFR remains at least more than 60 ml per minute for FTC TDF or at least 30 ml for TAF and FTC. If eGFR is declining steadily but still at an acceptable level for the type of oral PrEP medication being used, consider consulting a nephrologist for the needful. Screen all sexually active people for STIs, especially MSMs. Syphilis and gonorrhea for all PrEP users. Chlamydia, especially for MSMs and transgender women, even if they are asymptomatic. For every 12 months, monitor eGFR for all patients continuing on PrEP medication, monitoring triglycerides and cholesterol levels, and wait for patients who are on TAF and FTC. Screen heterosexually active people for chlamydia, even if they are asymptomatic. As of now, the availability of injectable PrEP is not, availability of the injectable cabotegravir is not available in India. So the ongoing assessments, we can skip this slide because it is not available readily in India now. So handling in indeterminate HIV test results. If a patient has an indeterminate HIV test results at follow-up visit, this is a tricky situation. Clinicians should work out to confirm the patient's true HIV status. Work with the patient to assess whether they have taken their PrEP medication as prescribed regularly since the last negative HIV test. Wait for a few days and then draw a new blood sample for repeat laboratory testing. These specimens should be tested using both an HIV antigen and antibody with a P24 and if required a PCR test also. If the repeat testing results show the patient has HIV, link them to the HIV care and linkage to care and HIV-HAART center. If the repeat test result confirm that the patient does not have HIV, PrEP can be continued. If the results are still unclear, try to get an expert advice. When the HIV status is confirmed for the patients using PrEP, prescribe a third drug, like in post-exposure prophylaxis. As in PrEP, we give 3-drug regime for 28 days. If patient is found to have HIV on further testing, this regime can be considered as early ART and think that it is early ART initiation and it is to be continued. This option is easily applicable for patients who took PrEP with poor adherence. Stop oral PrEP medication for 1 to 2 weeks to get a clear test. If the patient has HIV, briefly stopping PrEP allows time for HIV replicate to occur and increases the likelihood that an HIV test will detect the virus if it is present. This is telemedicine. Recently, after the COVID epidemic, telemedicine consultation replaced the clinic visits for PrEP. Conduct PrEP screening online, initiate PrEP and do follow-up visits by telemedicine consultations. Some laboratories in our areas are providing home sample collection services. Select a standard laboratory that conduct tests sensitive enough to detect the recent HIV infection. Once the HIV negative status is confirmed, consider writing a prescription for oral PrEP for 90-day supply rather than a 30-day supply. This will help patients to minimize trips to the pharmacy and to the clinics. Coming to how to discontinue the PrEP. How safely we have to discontinue and restart PrEP should be discussed with the patients both the times when they start the PrEP and when they discontinue the PrEP. The protection provided by daily oral PrEP wanes usually over 7 to 10 days after patient discontinues its use. Because some patients have acquired HIV soon after stopping oral PrEP. So physicians should assess ongoing risk for HIV and discuss other preventive methods if HIV exposure is anticipated, including the PEP. For injectable PrEP, cabotegravir levels slowly wane over many months after injections are discontinued. At some point of time during this tail phase, cabotegravir levels will fall below a protective threshold and persist for some time at a non-protective levels. For these reasons, patients discontinuing cabotegravir injections who may be at ongoing risk should be provided with another highly effective HIV preventive method during the months following their last injection. Clinicians should counsel the patients about the risk of developing drug-resistant HIV during the tail phase after the cabotegravir injections are stopped or when the injections are missed. Additionally, healthcare providers should assess patients' ongoing risk of HIV exposure and prescribe daily oral PrEP within 8 weeks after the last cabotegravir injection or other prevention methods If HIV exposure is anticipated, they should be added a PEP also at that period. Finally, physicians should continue follow-up visits quarterly for 12 months and conduct antigen antibody and HIV RNA test at each visit. What are the special considerations for special populations? Coming to MSMs, this is called on-demand PrEP or event-driven PrEP or coitally dependent PrEP. This is called, otherwise called as a 2-1-1 dosing PrEP. This 2-1-1-1 dosing on-demand or event-driven or coitally dependent PrEP, healthcare providers can prescribe this FTC TDF. This is an off-label prescription. It is not approved. Using 2-1-1 dosing for MSMs who request non-daily dosing, having sex infrequently, for example, less often or less than once a week. They can delay, while taking this tablet, they can delay sex to permit the first two pills, pill dose to act at least 2 hours prior to the sex. When using 2-1-1 dosing, the patient takes TDF FTC doses based on when they plan to have a sex. This is the regime. 2 pills, 2 to 24 hours before sex. 1 pill, 24 hours after the first 2 pill dose. 1 pill, 48 hours after the first 2 pill dose. If patient continues to have sex after 2-1-1 dosing period, the patient should take additional doses like this. If the patient has sex on the day after completing 2-1-1 dose, take 1 pill per day until 48 hours after the last sexual event. If the gap of less than 7 days occurs between the last pill and the next time they have sex, resume 1 pill per day. If the gap of 7 days or more occurs between the last pill and the last time they have sex, start again the 2 pills. This is a complex regime. These are all complex regimes. 2-1-1 dosing should not be prescribed for patients who might have problems, adherence problems, and to a complex dosing regime, such as adolescent patients. Usually they won't follow, and patients with an active substance use disorder. Note that 2-1-1 dosing is not approved by FDA and it is not recommended by CDC. So in this context, cabotegravir injections may be appropriate for people who have problems taking PrEP injections as prescribed. Let us see what is seasonal PrEP and transition PrEP or bridge PrEP. Seasonal PrEP is considered for individuals who travel for a longer periods in a high prevalence setting for a specific period like some holiday trips and holidays. So in this case, initiate PrEP prior to starting of a trip, 7 days in men, 21 days women and transgenders. Continue it for 28 days after the last sexual encounter. Follow the guidelines of daily PrEP initiation and follow. So transition PrEP is bridge PrEP is another type of PrEP in serodiscordant couples in which the uninfected partner uses PrEP till the time the infected partner achieves the below detectable levels with ART. PrEP for transgender people. Transgenders who use gender-affirming hormones having HIV risk factors can use PrEP. Although clear data on whether PrEP interacts with the hormone therapy used by transgender women are lacking, present evidence suggests that there are no drug-drug interaction with hormones. There are 3 PrEP regimens approved for transgender women and other people assigned male at birth. Daily oral TDF FTC or TAF FTC, cabotegravir injections every 2 months. There are 2 PrEP regimes approved for transgender men and other people assigned female at birth who may have receptive vaginal sex. Daily oral TDF and TAF, cabotegravir injection every 2 months. Transgender men who engage in receptive vaginal intercourse should not use daily oral TAF FTC for PrEP. TAF-FTC is not approved. It is also not approved for people assigned female at birth who are at risk of getting HIV through receptive vaginal sex. PrEP used in pregnancy and breastfeeding. Studies have shown that the risk of getting HIV is higher during conception and lactation, especially when people are having sex without condoms. PrEP with TDF and FTC or cabotegravir can help to protect people who are seeking to conceive or who are pregnant or breastfeeding and have a sexual partner with HIV, especially if the partner's viral load is unknown, is detectable, or can't be documented as undetectable. TDF, FTC, and cabotegravir are FDA approved for use by women and other people at risk of getting HIV through vaginal sex, including those who are pregnant or breastfeeding. TAF-FTC is not approved for use in women or other people who could get HIV through receptive vaginal. Earlier we discussed this. If the partner's viral load is less than 200 copies per ml or undetectable, there is effectively no risk of transmitting of HIV through sex, as all of us know. U is equal to U. However, PrEP may provide additional protection if the partner's viral load is inconsistently undetectable or if there are multiple sexual partners. The effects of PrEP on babies exposed to the medication through breast milk have not been studied till now. However, studies of mothers with HIV who breastfed while taking antiretroviral medications for HIV treatment suggest that babies have limited drug exposure through breast milk. PrEP for adolescents. TDF-FTC, TAF-FTC, and injectable cabotegravir are approved for PrEP in high-risk adolescents weighing at least 35 kg in combination with other safe sex practices to reduce the risk of sexually acquired HIV. We discussed earlier that adolescents and young adults aged between 13 to 24 comprises about 20% of all new HIV infections in United States. Commence hepatitis B and human papilloma virus vaccines to all the PrEP users if indicated. So this is completion of PrEP. Now we discuss PEP briefly. This PEP is the use of antiretroviral drugs after a single high-risk event, either non-occupational or occupational exposure, to stop HIV seroconversion. PEP must be started as soon as possible to be effective and always within 72 hours of a possible exposure. PEP should be given for 28 days. So in clinical studies for PEP, TDF-FTC and integrase inhibitor is a preferred regimen. The role of tenofovir alfanamide in PEP, there is no adequate data, but in day-to-day clinical practice, we are routinely using TAF, but as such, there is no data to use TAF in post-exposure prophylaxis. Before initiating PEP, rule out HIV and HBV infections. PEP should be given for 28 days. And as you know, the TDF, FTC, and integrase inhibitor is a preferred regimen. This is the algorithm given by CDC for the evaluation of possible non-occupational HIV exposure and treatment with PEP. PEP is also very effective. If taken with a good adherence for 28 days, it has 98 to 99% efficacy. In a high risk, either in non-occupational or occupational exposure settings, if the HIV positive source is an ART and has an undetectable viral load, PEP is not recommended. So nowadays, PEP is overused and it is over-prescribed. So if the source patient is undetectable, if you can able to see that, there is no need for PEP. Let's summarize the entire thing. So we have covered in this presentation. So PrEP is a two-drug PrEP is a two-drug combination of ARVs taken to prevent HIV and can be used by adults and adolescents at risk of getting HIV. Obtaining a brief sexual history from each patient is very important. Prescribing PrEP can be easily integrated into primary care settings. In fact, PrEP is similar to other preventive medications such as oral contraceptives for pregnancy prevention, statins for people at high risk of getting cardiovascular disease, and metformin for people of risking getting diabetes. Several NGOs like Accelerate and Mitra clinics for LGBTQIA plus communities will assist in taking PrEP, especially to transgenders and MSMs. 3 PrEP medications are approved in India: TDF-FTC, TDF-3TC, TAF-FTC. Clopidogrel IM injection is still not available in India at present. Consider PrEP as one of the comprehensive HIV preventive strategies, which should also include condom use and treatment of STIs. All three will go together. Any registered medical practitioner with little training in national HIV treatment guidelines can provide PrEP. Specialization in infectious diseases or HIV care is not required. PrEP is usually well tolerated, and it is 99% effective in preventing HIV transmission through the sexual route and at least 74% effective in preventing HIV transmission in IV drug users. PrEP can be prescribed to any adult or adolescent patient who asks for it, even if they don't report specific risk factors for the acquisition of HIV. Patient may ask for PrEP to protect themselves, but are sometimes unwilling to share more information about their sexual behaviors with healthcare personnel if they fear encountering stigma or discrimination. Having cordial conversation about PrEP with the patients can help them to overcome embarrassment about their IV drug injections and sexual behaviors. Additionally, clinicians should prioritize taking sexual and substance use history from all the patients. This information is essential to understand each patient's risk of getting HIV, and PrEP might be the choice for them. Advise: PrEP and PEP as and when indicated. Prevent HIV, stop AIDS. Thanks for your patient hearing.
Thank you so much, sir, for valuable insights on PrEP and PEP. So, sir, we have some questions in the chat box, which I would like you to address. There are quite a few. So, first question is from Dr. Narendra Bhai Rambhai Patel. He asked, do all high-risk diabetic patients be on insulin before PrEP?
So usually giving insulin in a uncontrolled diabetes is a preferable choice of treatment. But PrEP, because PrEP contains weight gain and metabolic complications are known with, when combined, actually TAF, it is known for causing weight gain and metabolic problems. If the really sugars are very high, controls are very poor, like when the HbA1c levels are very high and if the sugar levels are crossing more than 300, better to put the patient on insulin and give PrEP.
Okay.
But PrEP, there is no role of integrase strand transmit inhibitors, but INSTAs have some interaction with metformin, diabetics. That is another point, but in those cases, insulin is preferred. But insulin is also an anabolic hormone, may facilitate weight gain along with tenofovir. But along with TAF. TAF insulin weight gain studies are not done probably.
Okay. So next question we have from Dr. Rajesh Sethia. He asks for preferred investigations to rule out chlamydia and gonorrhea.
Gonorrhea is a smear. Urethral smear demonstrates the diplococci. Chlamydia it's difficult, but PCR for chlamydia may be a very reliable investigation. But symptomatically we treat, but as such chlamydia, straight away, there is no, you can do the serology and PCR maybe confirmative.
So next question is from Dr. Vishal Gupta. He asked that healthcare workers who are exclusively for HIV patients unit or the medical technologists who are at ICTC unit handling HIV positive blood, is there any role or indication of PrEP?
As we discussed in this thing, these people will encounter an occupational exposure. So source patient condition and the scenario with the exposure is very important. If, as we discussed in this presentation, if the source patient is already on ART medications and maintaining a below detectable viral loads, there is no need for PrEP. So PEP is not indicated, but not always we can get source patient details. So in that scenario, in the doubtful scenario, to eliminate it is in the discretion by case-to-case basis. If there is a strong injury suggesting deep injury and grade 2 injuries, then we can consider giving PEP.
Okay. One more question from his side. What is the current status of PrEP in India? Can it be given in government institutes, or only it is limited within the private sector?
As we discussed in our presentation, that PrEP has come into existence in India some 10-15 years back, but it doesn't come very, the PrEP usage in India is very, very less because of PrEP is mostly useful for MSMs and transgenders, and those in that particular segment, the PrEP usage is there. In India, because the discrimination, stigma, this is the main cause for PrEP being not used properly. But nowadays, all these voluntary organizations, all these groups, LGBTQ plus groups and all, and the voluntary organizations like Accelerate, Mitra clinics, they are bridging between the treating doctors and these key populations. With their intermediate link between us and the key population, PrEP usage has been increasing, but educated MSMs and all are directly coming to clinics and asking for PrEP. But I think in coming few years period, PrEP usage will be very much increased, tenfold increase will be expected in coming 2-3 years.
Okay. Thank you, sir. Next question is from Dr. Tarun. He asked that can we prescribe FDC of TLD, TLE if TDF 3TC or TDF FTC is not available?
Madam, please repeat the question.
Yeah, sorry, sir. So can we prescribe FDC of TLD and TLE if TDF and 3TC or TDF and FTC is not available?
So actually in our NACO guidelines, only TDF, TDF and 3TC is recommended by NACO for PrEP. TAF FTC is not there in the PrEP guidelines of NACO. So it can be recommended. Only difference is the creatinine clearance. If the creatinine clearance of an individual is less than 60 and more than 30, TAF can be given. If it is more than 60, TDF can be given. TDF and 3TC can be given, but only thing is a monitor kidney function once in every 3 months, 6 months and 1 year, because a transient rise in creatinine is expected with TDF, but real EGFR will not decrease. Creatinine values may increase, but once the drug is stopped, usually these things will be, but the PrEP, if you use for a longer time, years together, As like any other TDF preparation, so there the kidney function has to be monitored. So TDF associated nephrotoxicity, tubular toxicity is reported in several cases, but in PrEP cases, renal toxicities are rarely reported in India.
So similar to what you just mentioned, just an extension of the same, Dr. Ravi Teja asked that for how long PrEP can be advised in individual with prolonged high-risk exposure?
As long as the person is under constant exposure, it is indicated. The other partner, if the partner, the PrEP taking person, if he is in the risk of getting HIV, it is indicated as long as he is in the risk period.
So next question is from Dr. Sanjay Swain. He asked that can TLD be used for both PrEP and PEP?
Yes, madam. Yes.
Okay. I think that's all with the questions in the chat box, sir. Audience, if you have any more questions, now is the time to ask. In the meantime, thank you so much, sir, for your valuable insights. We sincerely hope that you all found today's webinar to be informative and enlightening. The knowledge and perspective shared by Dr. Satyanarayana sir will be surely will have a lasting impact and will definitely help you all to navigate the challenges in utilizing and implementing PrEP and PEP. I would also like to thank all our delegates for your time and active participation and their valuable contribution throughout the webinar. So Dr. Mayank Kekar says that the session was very informative and it was a very simplified presentation. Same from Dr. Dipali Srivastav. She's thanking you, sir.
Thank you very much for giving me this opportunity to share my experiences with you.
The pleasure is all ours, sir. So let us conclude today's evening. Thank you everyone for your active participation and your time. Thank you so much, sir, for sparing the time and educating us about PrEP and PEP. Hope you all to see you soon in the future. Wishing you all a continued success and a bright future. Good evening and good night. Thank you so much, sir. Thank you, delegates.
Thank you very much.
Thank you, sir. Wow.